Good evening, everyone, and welcome to our Managing Hip Pain webinar. I'm Lauren, your host and Private Patient Advisory Team Supervisor. I'm delighted to introduce Mr Syed Ahmed, a Consultant Orthopaedic Surgeon with a special interest in hip surgery. He performs a high volume of hip replacements annually, as evidenced by UK National Joint Registry, and is among the highest volume hip surgeons in the country. His positions of responsibility include Regional Clinical Coordinator for the National Joint Registry of South East, Training Programme Director for Core Surgical Training for Health Education Kent, Surrey and Sussex, and College Tutor at Maidstone and Tunbridge Wells NHS Trust. He is also a member of the Professional Affairs Committee of the British Hip Society. He has received notable awards such as the British Hip Society Travelling Fellowship, the Current Concept in Joint Replacement Scholarship, and the European Hip Society Travelling Fellowship. Before I hand you over to Mr. Ahmed and his presentation, please can I remind you that this is a live recording event and the recording will be emailed to you. Please be aware that we won't be able to respond to raised hands directly, but please do drop any questions you have in the Q&A section and we'll ensure to address them during the dedicated segment later in the webinar. Once again, thank you all for joining us and please welcome Mr. Syed Ahmed.
Thank you so much. Thank you, Lauren and Martha, for the invite, and thank you for that introduction. I'm going to spend about 20-25 minutes going through hip pain, and I'll be happy to take questions following that. So a little bit about me. I'm a fellowship trained hip and knee surgeon. I did a fellowship in Toronto in Canada on hip and knee arthroplasty, following which I was at University College London Hospital. Lauren's already told you the roles and responsibilities that I hold both regionally and nationally. My main interest is in hip replacements and revision hip replacements. So I mainly perform a lot of primary hip replacements and redo hip replacements for when hip replacements fail. So the goals of the talk are going to be to go through what hip pain is, how we assess hip pain and investigate hip pain, and then what the management options are depending on what the cause of the hip pain is. So a little bit about anatomy of the hip. So the hip joint is a ball and socket joint, and it sits really in your groin. So a lot of people look at the hip and they think it's on the outside of the hip, but really your hip joint, the ball and socket part of the hip joint, is in the groin. And as you can see in that image there, the ball and the socket are lined by cartilage, and this cartilage allows smooth movement between the two surfaces. Over the years, especially in osteoarthritis, what happens is that cartilage starts to wear off, and that's what gives you the pain. Now, depending on what the cause of, depending on the pathology that's causing the pain, you may have different symptoms in relation to your hip anatomy. So the number one feature that I want to know from any patient who is in clinic and comes in complaining of hip pain is where the pain is. And usually what I tend to ask my patients is, can you point to where the pain is with one finger? So what I want to know is the pain in the groin? Is the pain on the outside of the hip? Or is the pain around the buttock? Does the pain travel anywhere? So generally with hip joint pain, I'd expect the pain to go from the hip to the knee. So a lot of people get referred pain from hip pathology to the knee because the hip and the knee are supplied by the same nerves. And the femoral, the sciatic, and the obturator nerve supply both joints, and generally your brain perceives pain coming from the hip as coming from the knee. On the other hand, if you have pain that's around the back, the buttock region, this is likely to be pain coming from the lower lumbar spine. It's usually the sciatic nerve that's being pinched or pressed here by a disc or by arthritis, and that causes sharp shooting pain into your buttock, potentially traveling down the back of your leg. So this is not a hip joint issue. What I also want to know is what this pain is stopping you from doing. Is it stopping you from putting your socks and shoes on? Is it preventing you from getting in and out of the car? Or are your activity levels quite high? So is it preventing you from going for a jog? Is it preventing you from playing golf? And I want to know a bit about your general medical history and social history to establish if you're a suitable candidate for surgical intervention. So in terms of hip pain, I'll gloss over these slides, but based on where the pain is, if the pain's on the outside of the hip, then the cause is not going to be the ball and socket joint. The cause is going to be more of a tendon issue, such as gluteus medius tendinitis, which is a tendon that's on the outside of the hip. It may well be great trochanteric pain syndrome. And pain that's in the groin is likely to be coming from the hip joint itself. So it could be a labral tear, it could be arthritis, it could be femoroacetabular impingement. And pain that's usually at the back, so posterior buttock pain, is pain that's likely to be either a muscular issue or most likely buttock pain is coming from the bottom of your spine and not from your hip joint. Now, in terms of examining the hip joint, you want to see what you are like when you're standing up. Do you have a bit of a pelvic tilt? Are you compensating? So are you offloading the painful hip? And then the next thing with you sitting up or lying down is to check for how much movement there is in that hip. So what I'm specifically looking for is how much you can rotate that hip, how much you can flex that hip. So can you bring your knee in towards your chest, and can you take your knee backwards? And these movements are responsible for simple activities that we do. So for example, to be able to put your socks and shoes on and to be able to do your laces, you've got to be able to flex your hip to just about 100, 110 degrees. You've got to be able to externally rotate your hip, and you've got to be able to bring that foot up in order to be able to tie your laces. So you need quite a bit of movement in your hip to do a simple task, such as putting your socks, shoes on, or tying your laces. Now, there's some specific tests that we can do to establish if the pain is not arthritic, but actually coming from something called femoroacetabular impingement or a labral tear. And those are Faber and Fader tests. And again, over here, you can see in this picture, she's demonstrating simple rotational movements of the hips, just holding the knee and gently moving the leg to see if you can actually rotate that hip. And a lot of the time in my clinical practice, if what I'm suspecting the patient has is osteoarthritis or rheumatoid arthritis, all I need really is a simple x-ray. So usually people have seen multiple physiotherapists, they've seen GPs or someone in MSK, and they've had a lot of CT scans and MRI scans done, but no one's actually done a simple x-ray to say this is just an arthritic hip. Now, we've discussed this as a cause of hip pain, so pain on the outside of the hip. So you can see here that there's a couple of bursa, which is fluid-filled pockets that sit on the outside of the hip and also sit at the front of the hip. And if these bursa get inflamed, then they can mimic hip pain. And for this, one does not really require surgery. What you need is simple anti-inflammatories and potentially a steroid injection. So I touched on femoroacetabular impingement. Impingement, there's two types of impingement. Now, this is not arthritis, but it could lead to arthritis. So as you can see, going from the pictures from the left to the right, what you will have is generally a bit of over coverage of the ball part of the hip, or you could have a little bump on the neck of the hip that's impinging against the socket. So there's two different types of impingement, and what that will lead to is that when this person flexes their hip beyond 90 degrees, it may well cause impingement there. And as a result of it, you develop an arthritic hip over the years if it's not corrected initially. Now, osteoarthritis is the most commonest cause of hip pain. And the simple reason behind that is that they've lost all the cartilage between the ball and the socket. So you can see here on the left what a normal hip is meant to look like. So you've got space between your ball and socket, but on the right, over the years, they've lost all that space and you've got bone grinding against bone, and therefore simple movements become extremely painful. And this pain usually presents in the groin, radiating into the knee or radiating to the outside of the hip. And initially, what you've got to try for this is simple painkillers like paracetamol, ibuprofen. There's some physiotherapy to see if that helps. But eventually, when you have bone-on-bone arthritis, this is now a mechanical issue. And the only solution for it is a total hip replacement. Now, osteonecrosis or AVN of the hip is another common cause for hip pain. And what happens in osteonecrosis is that the blood supply to the ball part of the head, the femoral head, gets compromised. And there are a number of different reasons why this could happen. So the direct causes or why the blood supply could get compromised, the indirect causes. So these patients, unlike osteoarthritis, they have an insidious onset. So the movement in the hip is well maintained, but they come in complaining of groin pain and hip pain. And it's especially present when they've spent a lot of time working on that leg they go on long walks, or they've done some physical activity. It tends to be in a younger cohort of patients too. And they haven't completely worn out the cartilage, but certainly the ball part of the hip is unable to cope with the pressures that's being based on it. And as you can see from the MRI scan on the left to the right here, I don't know if you can actually look at what I'm pointing to. So you can see here, this is a really good oxygenated femoral head, whereas here you can see that it's all black and it's devoid of oxygen on this. So this femoral head generally has poor blood supply, and that could cause quite a bit of pain as a result of it. And initially, there's quite a lot of treatments. If it's picked up early, you can manage osteonecrosis by decompressing the femoral head, by medications. But eventually, when the cartilage loss has occurred or there's flattening of the femoral head, the answer really is a total hip replacement again. Now, back pain. I spend a lot of time in clinic trying to establish if the pain is coming from the back or if the pain is coming from the hip. Okay. And usually, as I've said previously, if the patient has buttock pain or pain radiating down the back of the leg or pain that's going beyond the knee. So generally, hip joint pain shouldn't go beyond the knee joint. So hip pain is referred into the knee, but not beyond the knee. So if you've got pain that's traveling all the way down your leg into your foot, or all the way traveling down the back of your leg beyond your knee, then that's likely coming from the back. So groin pain is pathognomic of hip joint issue, but buttock pain is more likely coming from your back. So there are specific symptoms of people who have hip osteoarthritis as opposed to people who have spinal canal stenosis. So tingling, numbness, sharp shooting pain, pain beyond the knee, it's most likely to be a back issue rather than a spine issue. And again, examination of this person's hip will show that actually hip movements are reasonably well maintained. But if you try and stretch the sciatic nerve by straightening the leg, that may well cause the pain. Now, it's likely that people can have both issues in the hip and issues in the spine. Okay, generally, most people you'd expect by the time in your 70s that you have a bit of arthritis of both your hip and your spine. The question then to answer is what is causing most of the pain? So what is the primary driver of the pain? Is it the back or is it the hip? And one of the ways I distinguish this is if you've got a back issue, which has been proven on an MRI scan, and you've got an arthritic hip, and we can't establish what's really causing most of the pain, then I will send you off to have an injection into your back to see if that gets rid of a lot of the pain. And if it does, then you can potentially avoid a hip replacement. Whereas if despite the injection you carry on having hip pain or groin pain, then you know that you're probably headed towards having a hip replacement. So there's certainly an overlap of symptoms and they can occur in tandem. And we've just got to establish what's causing the functional limitation. Is it the hip arthritis or is it the back arthritis? Now, if you go towards hip replacements, there's a lot of interest in how you're approaching the hip. But this is getting quite technical. And a surgeon chooses which approach they use based on a number of different factors. One, where they've trained. Two, what they're comfortable with in terms of their skill set to be able to get to the hip. And as you can see here, there's 4 or 5 common approaches that are used to get into the hip. But the most commonly used approaches are the anterior approach and the mini posterior approach, or traditional posterior approach. And the differences really are not that significant. So there's a lot of battle, especially in international hip meetings, about which approach is better. But the hip community is fairly split. And the way I like to look at this is in terms of looking at a Porsche and a Rolls Royce. So the Porsche is new, it's cutting edge, it's very exciting, and that's what an anterior approach is like. It's very new, cutting edge, a lot of people keen to get onto the bandwagon and get that. Whereas a posterior approach is like your Rolls Royce. It's well established, it's been there for years, it's smooth, there's no issues in terms of the view of the hip joint, and if you encounter any issues or complications, you can always extend it to be able to deal with any problems that may be thrown your way. And what I perform is a mini posterior approach, so minimally invasive surgery. And you can see these are patients who've consented for me to show their wounds. This lady on the right was very pleased that I didn't disturb her tattoo. And it's not just about the skin incision. What it is also about is preserving the muscles on the inside of the hip. So essentially your gluteal muscles, your abductors, So you make sure you don't disturb any of them. So then when the patients get up and walk, they're in less pain and they have the power to be able to go back to all normal activities fairly quickly. So you can see here in the traditional posterior approach, we come across a few muscles which we use retractors to move away from the view of the hip joint. You reflect a few of the tendons at the back and then repair this at the end. And that allows you to then perform the hip replacement. And as a result of this, I've been able to do the first day case hip replacement in Kent. And now 10% of hip replacements that I do are able to get up and walk the same day and go home and sleep in their own bed at night. So you can see with this gentleman here, let's see if you can see his video. So he was back on the ward at 10 o'clock in the morning, and this is 5 o'clock in the evening. So he's able to get up, he's able to walk without any crutches and a very slight limp. So minimally invasive surgery does have significant advantages in the motivated patient. So what are we doing in a hip replacement? So you can see on the picture there on the left, you've got this worn out hip joint where the ball and socket are completely worn. And these are the implants that I traditionally use, which is an uncemented stem that press fits into your thigh bone at the top. And then you've got a press fit socket with a new ball and a new liner that compensates for the cartilage that's been worn out. And overall, it's a very successful operation. It's been deemed the operation of the century. It's the second most successful operation in the history of surgery, with cataracts being the most successful. And I come from a family of ophthalmologists who keep reminding me of that. But patients who've had a hip replacement with the help of the MIS technique allows them to have accelerated rehab and get up and walk, as you can see, the same evening or the next morning and go home the next day. And the next thing that I tend to get asked, apart from the approach, is what sort of implants you're using. And although this doesn't really have much of a bearing on the outcome of the patient, the implant I use is really based on bone quality. So as you can see from on the screen there, if I go from left to right, you can see the thickness of the bone cortices here in this picture on the left, as opposed to one over here on the right, which is extremely thin. So as some people get older, they tend to lose bone mineral density, and they develop either osteo. They develop signs which are similar to osteoporosis. And if you've got an osteoporotic sort of bone structure, then you probably benefit from having an implant that's a cemented implant. So you can see on this slide here, that's a cemented implant. You can see cement around the implant. Whereas if you have really good bone quality, then you can have an uncemented press fit implant. So this is a decision that I make based on the x-rays and based on what I find when I'm operating on your hip. Okay. And there is a National Institute of Health research paper that suggests that the implant choice is almost as important as using your surgeon, as which surgeon you have. So does one size fit all? No, it doesn't. And you occasionally come across patients who have variations in anatomy, and then you've got to decide what type of implant you're using based on the anatomy that you're dealing with. And therefore, a surgeon has got to have a lot of different options on the shelf to make sure we can deal with the patient cohort that we have on the table. So what are the common complications following hip replacement? So as I've already said to you, a hip replacement is a fairly successful operation. However, it is major surgery and there are complications associated with it. So the short-term complications are infection, risk of dislocation, leg length discrepancy. A lot of people tend to be, over the years, compensating and walking on a shorter leg. So when you tend to even them out following a hip replacement, they feel, whoa, my leg is a lot longer than the other side. And this is a common complaint for patients who've had a hip replacement. And on the x-ray, you can see that actually the hips are perfectly well aligned, but they feel that they're walking on a much longer leg because they're used to walking on something that's a centimeter half shorter for several years before they've ended up having a hip replacement. The long-term complications are you could have a fracture, they could be wear of the components, or loosening and failure. Now, I'm going to skim over that, but the other thing that patients want to know is what type of what material the hip replacement is made of. And the options that we have are metal on a really strong plastic, you've got oxinium on a really strong plastic, or you've got ceramic on a really strong plastic or on a ceramic liner. And generally, as you can see there, with this group of, I mean, that's metal on metal resurfacing, so we can discount that. But if you look at here, between metal on polyethylene, which is metal on plastic, oxinium on plastic, and ceramic on plastic, the differences really are minuscule. Okay, so having said that, on the younger patients, we tend to use ceramic because it has a slightly theoretical better wear rate, and on the older patients, we tend to use metal on plastic. And that's merely a cost thing as opposed to anything else. And the implants that all the surgeons now they should use is really a 10 A-star ODEP rating implant. So ODEP is the Orthopedic Device Evaluation Panel, and they rate implants. So they give implants a rating based on how long the implant has survived and what the risk of failure of the implant is. And if you're choosing a surgeon and you want to check what type of implants they're using, then you've got to ask them, are you using a 10 A-star implant? And at the Horder Centre, all our implants are 10 A-star implants. So this is a patient who's got X-ray of both their hips, and you can see the stark difference between the right hip and the left hip. On the left side, you can see that they've worn out all the space between the ball and socket there. So then the way you want to plan this hip replacements, we use a software, the Horder Centre, which allows us to plan what we are going to do prior to having gone into theatre. And this allows me to check what cup I'm going to use, what stem I'm going to use, where I'm going to make the cuts in order to be able to get their leg lengths to the millimeter correctly. You can then execute that plan intraoperatively. And once that's executed well intraoperatively, the survivorship of this hip is excellent. 85% of hips survive beyond 20 years, and 90% are successful beyond 15 years. So actually, the survivorship of hip replacements overall, even in our National Joint Registry, is excellent. And if hip replacements fail, you can see here, this cup is going into the socket, and this is one of my cases, which I've done. You get a CT scan, you make sure that you're doing the right thing, you plan for revision surgery, and over here I've used trabecular metal, which is a really strong sort of titanium to be able to accommodate the bone loss and do a new hip replacement. And this is another case here where there's a cemented hip replacement on the left side, which had failed at 15 years, and you can see I've corrected that by putting a new stem and a new socket in there to address the failure and the pain that the patient was experiencing. So what's new in arthroplasty? So given the fact that hip replacement is such a successful operation, we still want to be able to improve things. We want to be able to improve the patient outcomes. We want to be able to reduce the risk of complications. And the way you do that is there's been the modern designs. So in the high-risk patients who you think are going to dislocate, there's an implant called a dual mobility implant where there's two articulating surfaces, and this significantly reduces dislocation risk. There's a lot of navigation in arthroplasty generally, so with hip and knee replacements, so you're navigating it with the help of a computer screen to be able to put your implants in the correct place. And this is both with hips and knees, and there's robotics. There's a lot on robotics too. Having said that, there's this paper which shows that as far as hip replacements are concerned, robotics does not have a statistical difference in patient-reported outcome measures, and it's just longer duration of procedure. However, I do feel that it may well be the future, and in 10, 15 years, we will be using some sort of navigation or robotics or getting live information during a procedure to be able to put the implants in the right place. So this is my last slide. So just to summarize, as far as pain is concerned, you want to be able to identify where your pain is coming from. Is the pain at the front of the hip? Is it buttock pain? Does the pain travel down your leg? You want to see if you can move your knee comfortably. Femoroacetabular impingement is on a spectrum that will lead to osteoarthritis of the hip if not corrected early. And the management of hip pain really is in a stepwise progression. So if you have pain in the hip, you've got to try and reduce weight. If you're overweight, take simple paracetamol, ibuprofen before doing some physiotherapy and exercise. And if despite that, the pain is still persistent, then start with a simple x-ray to see if you can diagnose the cause of the pain. And if that doesn't do it, then you may well need an MRI scan of your hip or your back. So I will stop there and stop sharing my screen, and we will take any questions that you may all have.
Thank you so much, Mr. Ahmed, for providing us with a comprehensive overview, managing hip pain, and I'm sure many of us feel much more informed after hearing from you today. Now we'd like to open the floor to answer questions. For those of you who have submitted questions during the presentation, thank you. We'll get through as many of those as possible. If you haven't had a chance yet, please feel free to type your questions into the Q&A box and we'll do our best to address them. So I'm just going to have a look at those now. One question here, Mr. Ahmed. I have regular guided injections which help tremendously for about 6 months. When should you consider a hip replacement? How long should someone leave between an injection and surgery?
So I'm assuming what you have is a steroid injection. Now, steroid injections are a good way. So steroid injection is an anti-inflammatory. So it's like injecting ibuprofen or naproxen into the joint. Yeah. Now, steroid injections are a good way to delay surgery and manage the pain if you're not keen to have a joint replacement. Having said that, it's not a long-term solution. It's just symptom management. Okay, so if you are extremely young and you have mild to moderate arthritis, you don't have severe arthritis, and you just want to manage the pain, then a steroid injection is beneficial. Having said that, when you lose the space between the ball and socket and it becomes a mechanical issue with bone grinding against bone, a steroid injection is not going to cure that problem. So you could have a steroid injection 1 to up to 3 times, but I wouldn't really suggest it beyond 3 times. And there's now increasing evidence to show that repeated steroid injections do increase the risk of infection when you put metalwork in there. So if you have established arthritis and symptoms that are severe enough to warrant a joint replacement, I don't see any benefit of having any further steroid injections. You really got to consider having a joint replacement.
That's great, thank you. We have another question here. How do I know if I have arthritis in my hip or just normal wear and tear and they are 70?
So osteoarthritis is wear and tear. So wear and tear is osteoarthritis. Now you've got different levels of osteoarthritis. We grade them from grade 1 to grade 4. So in grade 1, you've got a bit of patchy loss of the cartilage, and grade 4, you've lost all the cartilage and you've got bone grinding against bone. So that's osteoarthritis. It is a medical term for wear and tear of the cartilage in the hip joint. So over the years, everyone will tend to have an element of osteoarthritis. So I've played tennis pretty much all my life, and I've got osteoarthritis on the inside of my knee. Now, it's early osteoarthritis, so it's not bad enough to warrant a knee replacement, touch wood. But the way you assess that is by how bad your symptoms are. Are they managed with simple painkillers, ibuprofen, anti-inflammatories, or by doing a simple x-ray where you can see how much of the joint space you've lost. So if you've got to a stage where you're requiring analgesia, painkillers, anti-inflammatories 4 times a day, and despite that you're not able to control the pain, then it's probably best you have that investigated with an X-ray or an MRI scan, and then that will tell us if you are a candidate for a hip replacement.
Brilliant, thank you. What would be the recovery times for a hip replacement?
So this is one of my keen interests, and the whole idea behind minimally invasive hip replacements and enhanced recovery is that you get people back doing the normal activities as quickly as you can. So as I've shown you from the videos, you have people walking the same evening if you have it in the morning, or the next day if you have it late in the afternoon. So you're up and about walking the next day once your anesthetic is worn off and your pain's under control. You're usually in hospital for 1 or 2 nights. Most of my patients stay in hospital for 1 night. And then the physios, especially the Horder Centre, are excellent, and they'll see you on day 1 post-op. They get you up walking with the help of crutches. They'll get you doing stairs. They'll get you to use the toilet safely and show you and make sure there are any precautions that you need to take. They'll make you aware of all of that. So then you can go home after 1 night stay in hospital. It takes about 2 weeks for the wound to heal. So the first 2 weeks are uncomfortable because you've got a wound, you've had major surgery, regardless of it being minimally invasive. So the first 2 weeks are slightly uncomfortable, and you've got a dressing on top of your wound. After 2 weeks, once the wound is healed, most people can go back to a lot of normal activities. By 4 weeks, you should go back to driving, and by 6 weeks, I'd expect my patients to be walking without crutches and being able to swing a club on the golf course.
That's great. Another question here. My hip x-ray showed marked degeneration, but on exam, consultant said my motion is good. Any advice for future?
So I think that's a very reasonable thing I think it's very reasonable there to manage it without hip replacement. If you've got good movement. Again, we're not treating the X-rays. So I do have patients who have an arthritic hip or an arthritic knee. You're not going to put them through a joint replacement just because you have an arthritic looking X-ray. It's all dependent on your symptoms. So if you're able to do your daily activities, like getting in another car, putting on your socks and shoes, and it's not stopping you from doing things that you want to do, then carry on. There's no reason to have a joint replacement. Having said that, if you've developed established arthritis, which is severe, on X-rays, it is likely that at some point you will have symptoms that reflect that. So you've just got to keep an eye on it. And if painkillers don't manage the symptoms, then you're looking at having surgery.
Thank you. What would you suggest in your view of hip dysplasia pain? What would be the main sort of
So,
suggestions of that?
so hip dysplasia is something that unfortunately people are born with. So just to explain to everyone, dysplasia is when the ball part of the hip is not covered by the socket. So it's only partially covered. So when you have a ball that's only partially covered by the socket, you can imagine the loading on the cartilage is quite abnormal. So there's increased loading on the part that's covered. And over years, they have a high risk of developing arthritis or wear and tear in that joint. So if you've got a dysplastic hip, you've just got to take precautions such as avoiding impact activities in order to try and prevent secondary osteoarthritis. So if you're known to have a dysplastic hip, you've just got to make sure you take all the precautions necessary to prevent yourself from getting an arthritic hip. So the cardiovascular exercise that I tend to recommend are closed circuit exercises, such as using a stationary bike, a cross trainer, or a rowing machine, where you don't have any impact through the joints. And this is what I tend to recommend to most people who have early arthritis in their hips.
Great, thank you. Another question here. I've been told that I have advanced osteoarthritis. How do I manage that?
So if you've got advanced osteoarthritis, and I think I've tried to have addressed
Yeah.
this a few times previously, it's again based on symptoms. So you want to manage it by doing physiotherapy, stretching, conditioning exercises, regular paracetamol, ibuprofen or naproxen, if you can take that with meals, and you want to take that 3 to 4 times a day. Now, if despite that the pain is still persistent, then the next step is seeing a hip surgeon to check if you need a hip replacement.
Great, thank you. The workup you described to match the operation and equipment to the patient is impressive. Does this depth of investigation happen in the NHS as well as the private sector?
Yeah, so this happens across my practice, both in the NHS and in the private sector. So all the hip replacements I do are templated on X-rays to make sure that we know exactly what implants we're using. There's no surprises when you're going into the operating room. You've planned what implants you're going to use. You've planned where you're going to make your cuts. So then you place implants to give patients an optimum hip replacement given their anatomy. Now, most surgeons should do this. I'm hoping most hip surgeons in the country do this, but I can't guarantee you that everyone does that.
I think the question that's submitted is against another one that's been raised. So my concern is that I do not have groin pain. I have significant limp. I have no pain on weight bearing. My pain is on sitting down and standing up in the buttock. I have also have new neuropathy on the top of my foot. I've been booked for a total hip replacement after the consultant looked at the X-ray, which concerns me.
If you've got buttock pain and you've got pain going down into your foot, or if you've got altered sensation in your foot, and if that is your only complaint, then I would suggest getting an MRI scan of your back before you have any surgery. Having said that, as I've mentioned to you before, you may well have back pain because of spinal pathology. So you've got an arthritic back or a disc prolapse. And in addition to that, you may also have an arthritic hip. So your X-ray would have shown that you have osteoarthritis of the hip if there's a surgeon who's listed you to have a hip replacement. But if you do not have groin pain and your main complaint is buttock pain with pain going down your leg, then you may well want to have an MRI scan of your back before you have any surgical intervention.
Thank you. I have recurrent bursitis in the left hip with tendon problems. I have now had 3 ultrasound guided injections and have been advised that a hip replacement is not required. I'm worried about continuing ultrasound guided injections long term because of the potential risk of infection. Have you any thoughts other than the pain relief I previously prescribed naproxen?
The most reassuring thing about trochanteric bursitis, greater trochanteric pain syndrome, is that patients don't come back year after year complaining of these symptoms. It does go away. Yeah. The cornerstone of treatment is stretching exercises to strengthening your abductors, using a cross trainer, rowing machine, or a cycling machine to do that, using ice packs. I strongly suggest Voltron ibuprofen gel. You massage that in on the outside of your hip, and physio really helps with that. The next step, yes, is anti-inflammatory such as ibuprofen, naproxen. I suggest taking that regularly, and then steroid injections. If you've already had 3 steroid injections, then I suggest spacing the steroid injections out and doing everything else to try and avoid having further steroid injections. Having said that, the issue with steroid injections is not infection. The issue with having repeated steroid injection is muscle attrition or tendon tears. So you want to try and avoid having too many. 3 generally tends to be my upper limit. Having said that, I have injected 4 or 5 injections in someone's trochanteric bursa if they have tried everything else, and despite that, they still have pain. So I strongly recommend trying all the other therapies and modalities to try and control the pain.
Thank you, Mr. Ahmed. So another question here, and I'm probably going to pronounce this word wrong, so maybe to help me out on this one. So treatment options for greater trochanteric bursitis with complication of hypermobile joints in late 60s female.
So GTPS, greater trochanteric pain syndrome, trochanteric bursitis, they're all a spectrum of the similar sort of pathology, which is inflammation of the tendons, the bursa on the outside of the hip. So as I've said, the cornerstone of treatment is starting with things like physio, stretching, conditioning exercises to strengthen your abductors, ibuprofen, Voltron gel, ice packs, and if that doesn't help, anti-inflammatory tablets. So you can take ibuprofen and naproxen tablets, and then steroid injections. So that's really the path that you will be following when you have a GTPS or bursitis.
Okay, great, thank you. So it looks like we just got one last question here. I have a Birmingham hip in my left hip. Is this still an option on my painful right hip? And is this a minimally invasive operation?
So hip resurfacings are not a minimally invasive operation. You need quite a big incision to be able to do a hip resurfacing. Having said that, the indication to do a hip resurfacing has significantly reduced. So it's difficult to answer that question without looking at how old you are, what your x-ray looks like, what your resurfacing looked like, and why you want to have a resurfacing as opposed to traditional hip replacements. And the reason why resurfacings have generally gone out of fashion is because of the high failure rate. So about 50% of resurfacings are converted to a hip replacement between 5 and 8 years. Whereas, as I've shown you the data on hip replacements, they have excellent survivorship at 20-25 years. So there's no reason to have a resurfacing when you can do really well following a hip replacement. Someone like Andy Murray, who's going to play Wimbledon, that can justify why he needs to have a resurfacing. Having said that, his resurfacing has now been converted to a hip replacement. So the lifespan of a resurfacing is certainly not as good as a hip replacement.
That's great. Thank you, Mr. Ahmed. Okay, so once again, thank you, Mr. Ahmed, for providing your insights this evening, and everyone who has taken the time to join us. If you have
thank you very
any
much,
further,
Lauren.
thank
and
you.
thank you, Marta, too. Thank you for organising and inviting me.
Thank you. So if you have any further questions or would like to book a consultation, please do not hesitate to contact us via the details that have been displayed on the screen, which is our telephone of 01892 620 939 or email pp@horder.co.uk. So thank you, everyone. Have a wonderful evening.
Take care. Bye.
Bye-bye.